So until the Neville sir is joining, I will tell we are going to change the Uromet. Up to now, we have conducted the lecture type Uromet. Now, today onwards, we are targeting the exit exam. So, Viva type of Uromet we will conduct. So, today is the starting session. So, we will do the how it happened. We will conduct that way. So this is basically FRCS urology exam equivalent type of exam. So exit exam. So you have 8 Viva panel during the exam. So out of 8, 1 is the BPH or the prostate Viva panel. So today is we are conducting BPH session. So continuously, not weekly, because we have enough time for preparing the exam this time. Mostly March or April will be the exam. So we have to do several sessions, as well as in between we will arrange the journal article, the journal club discussion. So that is the plan. So you can give me order in Viva, who are the people who join in for the Viva. Targeting group is the eligible candidate for this time exam. So the journal clubs, everybody should join for the journal clubs. That means that not everybody, all the trainees, including the first year and up to the completion of the local training. So that is the routine thing. And other message, the SLOUS and the PGIM subspecialty board team wants to emphasize all the senior registrars should attend to the Uromet. That is mandatory, because we are conducting this program for you, not for the consultants. They can join and they can listen, they can update the knowledge, but this is basically targeting our trainees. So we want to brush up our trainees' knowledge. At the same time, we can brush up our knowledge. So when you go to the foreign training, you will realize where we were, where we are. So because our knowledge is far behind compared to other countries. We are more workaholic. We do more surgeries. We are skillful sometimes, but the knowledge-wise we are lack. Because of that, we have to conduct this Uromet educational program, and all the senior registrars should attend and get maximum benefit from that. At the same time, you can everybody can give your opinions. We can consider and we can do the changes accordingly. Not the date wise now. A lot of arguments, and we have to change to the weekdays. But disadvantage of doing the weekdays, we can't get our UK colleagues' input. So they are actively involved. They are working places this time. So weekdays very difficult to get their help. So in between, at least we have to conduct few Uromet sessions in Saturdays, because we want to get their input as well. Still, I can't see the Neville sir is joined.
Excuse me, Muktesh, how often are we going to do the Uromet sessions? Every weekly or once in 2 weeks?
I thought if possible weekly we have to arrange, but not all the times we can't do. So in weekly basis, if we do, I have to think about when when is the next one? Because next week the problem is we have 28, 29 the pre-congress workshops going on in the College of Surgeons. So sometimes we are busy with that. Then following week the UA sessions is ongoing. So some of us is joining for the UA Congress. Because of that, in between weekday, I have to select. Most probably, I think next Uromet session I can ask to conduct on uh, 2nd of that is Monday. Third week, fourth. So
that is
next,
totally next in the September first week. It's usual they are in the
difficult,
program.
no?
Difficult,
Yeah.
probably.
Yeah. After the UA sessions, we will conduct the next session. Is it okay? So you have enough time. I will send the two journal articles. So you have enough time to get ready with the journal article.
Yes.
So,
Sir is joined now.
right.
Nabil, shall we start? Sir already joined.
Okay. Thanks. So welcome you all on behalf of SLAUS. Actually, all the candidates who is going to sit the exam, all are welcome, as well as those colleagues and masters. Everyone are welcome for this session. Actually, this will be a Viva session. I think I try to do it in a structured way. By in between, I will ask some questions and go with that, because that will guide you, and I can proceed you as what I am expecting and what you want to take. So it will be a better guidance as a Viva scenario, I think. So first I will let you to talk in the first of all. So we will start the Viva session. It will be lasting over the 20 minutes. So I have a set of questions and I will ask and we will go through. Madhushanka, are you ready?
Yes, sir.
Okay. This is a case scenario where the 65-year-old male patient who is presented with a weak urinary stream and difficulty in pass urine, who is referred from the GP. As in a clinic, how are you going to evaluate this patient?
So I got a patient with 65 male who complain of voiding LUTs. So in the evaluation, I'll go through the history, examination, and further investigations. In the history, I'll ask further details about his symptoms in view of the extent of the symptoms and the duration of the symptoms. Here, I'll inquire about the LUTs in view of voiding as well as storage LUTs and post-mutation symptoms, and how bothersome to the patients as well. And apart from that, I'll ask about patients' other associated symptoms like hematuria and dysuria symptoms as well. Then further inquired about the patient's lifestyle symptoms like patient's fluid intake, alcohol, caffeine intake, as well as the significance of symptoms to his day-to-day activities. And then patient's the medication history, whether he's already on any medications for the symptoms, or else patient is having other medications which will affect his symptoms like sympathomimetics and anticholinergics, and as well as whether he's on any diuretics for other drugs, other diseases. Then I'll inquire about his past medical and surgical history, where I'll go through any urethral interventions, previous surgeries, or else pelvic or abdominal surgeries. Same time, whether he's having any neurological conditions which can precipitate these kind of symptoms. Then I'll do examination where I'll focus on general as well as specific examination. General examination, I'll check patients' symptoms in view of renal failure, as well as patients having any neurological diseases. And specifically, I'll examine patients' abdomen in view of any palpable bladder, percussible palpable bladder, or bilateral loin masses. And I'll perform genital and digital rectal examination. And genital examination, I'll check whether there's any phimosis, urethral pathologies. And in the digital rectal examination, I'll see whether his prostate is enlarged or not, whether it is nodular, the consistency of it, in view of assessing prostatomegaly for the symptoms. Then after evaluating history and examination, I'll get the basic idea about the patient's the problem, and I'll inquire further symptoms by using a objective standardized questionnaire where I'll use the IPSS score. There are several scores are there, but standardized practice one is IPSS score. So with that self-administered questionnaire, I'll characterize this patient's symptoms into either mild, moderate, or severe symptoms. And then I'll go ahead with investigations of the patients, where I start with serum and urological evaluation by assessing serum creatinine and electrolyte to exclude renal involvement, urine analysis to see any urine infections, any evidence of microscopic hematuria or any proteinuria, and I'll do
just while I
patient.
just interrupt, yeah, Madhushank, a very well comprehensive answer on the history and examination, where you focused on the main aspect of the history and examination. So, regarding you have assessed the IPSS score as well. So, you said about the investigation where serum creatinine and electrolytes as a test. Is it really necessary in all patients when you evaluating the LUTs?
Not really indicated for all patients. If simple, mild symptomatic patients who are just presenting with LUTs, we don't need to do all the investigations. But if the patient
sorry, Madhushanka, when you will do the serum electrolytes and serum creatinine in the LUTs evaluation patient?
yes, if the patient is having concurrent association of hypertension and diabetes, where the renal involvement can be there, or if the patient is having history of long-term involvement suggestive of chronic retention, or if the patient is having features of acute or acute and chronic retention. So in this, and patients having general features of like body swelling, reduced urine output. So if I'm suspecting renal failure, in that scenario, I'll go ahead with renal function assessment.
Yes, Madhushanka. Okay. So that is a correct answer, where you have chronic features and palpable bladder or any evidence of renal failure, then only you will consider serum creatinine. Where anything, what you have about the UFR? Any impact on UFR or urine dipstick in the patient with the LUTs evaluation?
In EU guidelines, they recommend to do urine analysis in every patient who present with LUTs. Thereby, they just won't exclude the associated hematuria, as well as we can exclude the infections which can precipitate these LUT symptoms, especially patients who have short-term LUTs, and as well as some patients early renal involvement, like proteinuria, we can assess by doing urine analysis. So it is recommended in LUTs patient to do a urine analysis as a preliminary investigation.
So what is mean by, you have mentioned about the IPSS. What is mean by IPSS?
It is the short form of International Prostatic Symptomatic Symptom Score, which is introduced by American Urology Association, and which is nowadays worldwide practicing the commonest tool is there.
What are the components? What do you think the components of the
yeah, it is consist of 8 questionnaires. Out of them, 7 questions will assess the patient's storage symptoms as well as avoiding symptoms. And each symptom, they will give a value of 0 to 5. And same time, they assess the quality of life questionnaire, where they give 0 to 6 value. So this altogether, it gives a 35 value. Out of them, if the patient is having 1 to 7 the symptoms are like mild symptoms. So 8 to 19, it's moderate. 20 to 35, severe symptoms. And apart from that, they assess the quality of life by 0 to 6 score.
Right. Now this patient have a clinically benign prostate, which is a 40 cc prostate. The IPS score is 18. So how we are going to proceed this patient after that? There is no neurological features, no renal failure features, only the clinically benign prostate with the 40 cc clinically, and there is no suspicious features. How are you going to evaluate this patient further?
Yes. So this patient belonged to moderate symptom according to this IPS score. So I further evaluate this patient by doing basic urodynamics. There I'll ask for ultrasound scan along with the post-voidal residual. There I'll see confirm the prostate size as well. Apart from that, post-voidal residual volume can be measured. And then I'll go for a frequency volume chart where it will give the patient's frequency as well as the volume, and I can see whether there's any element of polyuria. And same time, as it's 40 cc prostate, I'll do PSA just to not to exclude malignancy, but at the same time, I want to get the idea about the disease progression of BPH of this patient. And with this evaluation, I'll get the idea about the disease status, and then I'll start.
Yeah, yes, Madhushankar. Are you going to do the PA? You know, this is patient age and everything. What will you tell this patient doing a PSA clinically benign prostate, 65-year-old? Are you going to do the PSA? What is the rationale?
Yes, in this 65 patient, it's a like opportunistic screening in view of malignancy, but here the main focus is not to exclude malignancy as it's a clinical prostate. I educate the patient that by doing PSA, there's a possibility that if it is rising, we have to evaluate in view of malignancy. But here I want to assess the initial preliminary PSA value. If it is more than 1.5 nanograms per milliliter, it gives that patient is more likely to get more disease progression, as well as in the future he will go into retention, and the disease progression wise I can get the idea. And there are some studies that this by doing initial PSA which can predict the prostate size as well. So it is basically like preliminary workup investigation, which is also recommended by EUA.
What study you said about the prostate size which is relevant to the PSA?
The name is not specified, but there are certain studies. They mentioned that the relevant PSA value will predict the size of the prostate as well as the outcome of the BPH in a patient.
Right. So are you going to the, you mentioned about the ultrasound scan and residual volume. Are you going to the upper tract evaluation as well? No, otherwise you will do only residual volume in this patient.
Here, my main target is to assess the residual volume only, but the upper tract evaluation is not really indicated in this patient. But as we are doing a scan in a like general way, so we can assess both upper tract and lower tract at the same time. But as specifically for this patient, it's basically I want to assess the post-voidal residual and the bladder assessment only.
Right. Then further, how will you going to proceed this patient? Now you have done ultrasound scan residual volume. It has shown around 100 ml of residual volume with the pre-voidal around 500 and post-voidal around 100, and with the urinary flowmetry showing around 12 ml per second with voided volume of around 300. So how are you going to proceed?
Yes. So the summary of this investigation will show that the patient is having the evidence of blood outflow obstruction, and same time in the history I go through whether the patient is having any complications of the disease as well, like UTIs, stones, and recurrent infections, as well as patients having any episodes of acute retention. And excluding those things, I'll discuss with the patient the treatment options is having. So the treatment options are either we can start with medical management or surgical management. But as like first line treatment, medical management would be better. By starting, there are same time I can start with lifestyle modifications as well. In the medical management, the first line treatment would be alpha-1 antagonist, where I'll start with tamsulosin as 0.4 nocte daily dose. And at the same time, I'll educate the patient about lifestyle modification, where I'll adjust his fluid intake, the reduction of excess fluid intake after 7 o'clock, as well as the frequent voiding and time voiding. And if he's had a sensation of post-voidal residual volume, double voiding. And apart from this lifestyle modification, specifically reduction alcohol intake, cessation of alcohol as well as smoking, and avoid constipation. So advising this lifestyle modification, I'll start with medical management. And with the time, I'll
Yes.
reassess the patient in view of improvement of IPSS and the repeat the post-viral residual to assess the reduction of post-viral residual volume.
Right. Right. Now you think before starting this stem solution or anything, so just I want to ask some other question. Where are you consider the advanced urodynamics in the patients in the LUTS evaluation? Is it necessary, or when you will do consider that?
In a patient with LUTS, as a routine evaluation, there's no place for urodynamics, advanced urodynamics. But in specific scenarios, if the patient's having this, apart from the basic symptoms, if he is having concurrent neurological problem, where we can't clearly categorize the LUTS into the prostate occlusion, we have to do advanced urodynamics. As well as if the patient is having significant post-viral residual volume, more than 300. Or if the initial voiding volume, he can't pass more than 150 ml of urine. Or in a patient who is having significant bothersome symptoms, the age is less than 50 or age is more than 80. And same time, if the patient had any previous medical management or any previous treatments where his treatment has failed. So like that, there are specific scenarios where I consider advanced urodynamics, but in routine LUTS evaluation, there's no place for advanced urodynamics as it is invasive.
Is there any studies they have proven that no urodynamic is necessary before the LUTS, because before treating the invasive procedures for the LUTS? Like upstream study, right? Yeah. Okay, they have no country because they are all the 90% of the people will have a usually blood out obstruction rather than the hypocontractive of the bladder. So that is the outcome where when compared to this thing. So most of the times intervention is needed with the medical management like this intermediate category. So okay, I think that almost 20 minutes have gone. So sir, so your comments, sir, from the sir's point of view, just expert side, sir, can continue some of the questions and clarifications, sir. Any problems?
Yeah. I think that's a good way of questioning. Thing is that now, so this is going to be the whole discussion on BPH, is it?
No, sir. That's actually there are so many questions, but I think that 20 minutes
parts.
Yeah, yes, sir.
The first 20 minutes, he'll be facing the questions, isn't it?
Yes.
I think it's pretty good, I think, the way it is going. So I'm just observing and trying to get used to this new format. So I think I'm just trying to find out what's my role is going to be like, So
yes, sir.
Because the two examiners seems to be they are good experts on the subject.
This is the actually the experts view. One thing is you have to guide the examiners how to conduct the exam as an examiner's role. What is we have to do? Second one is the candidate's point of view. How the candidate should improve answering the questions. So
Uh,
both of us have to guide in future. As a future examiners, we have to guide by our experts.
yeah.
Examiner point of view, our faults, as well as the candidates wise, how they should answer to the exam. So that is the ultimate purpose. That is why second line juniors are doing the examiner post rather
Yes,
than
but
the
yes. Yeah. Right. You can hear me, can you?
Yes, sir, yes.
Right. Fine. I think where Nabil was conducting it is quite good, but I would rather sort of break this discussion into many more questions, many more fragments.
Okay, sir.
Like, say, when you say ultrasound, I think you asked some very relevant questions, but the information also was asked. So in between, sort of more short questions, I think should be asked. And then otherwise, Madhushanka is quite well prepared, and this is kind of, quite, this first part is quite good. I think the way it went on was very well. So quite happy. So let's see how it goes, so make it more and more difficult for the candidate.
Yes.
So, I'm sure you are prepared with some more difficult questions when you go on, with the,
Yes.
it's going to be the BPH, isn't it? BPH
Yes.
topic. So,
Yes. Yes.
we'll see how it goes, and I will make my comments in between. Huh?
Yes.
Yeah, sure.
Okay, Madhushankar, we will continue. Madhushankar? Madhushankar.
Hello, yes.
We will continue some more questions because I have got into some of the questions. Actually, while before going to the Dunita, either probably you will be asked by the Dr. Munupriya. I will ask from the Dr. Madhushankar. So there are some of the questions I just want to finish it out and I have to get a clarification from Madhushankar. You told about before starting time solution, just I want to ask some other questions. Are you consider flexible cystoscopy in every patient who is evaluating a LUTS? Some of the centers they are doing, some of the dentists are not doing. So is it a consensus wise how? What is your rationale?
No, flexible cystoscopy also not a routine investigation in LUTS. I'll consider doing flexible cystoscopy in specific scenarios. Specifically, apart from LUTS, if the patient is having episodes of hematuria, either macroscopic or proven by urine analysis, or if the patient is having history of other urethral injuries, history of strictures, apart from like suspecting prostate, any other pathologies. Or if the patient is having a history of prostate carcinoma, and same time whether he's having recurrent LUTS or sterile pyuria. In specific scenarios, I'll do a flexible cystoscopy. Other than that, it is not indicated.
It mean that mean prostate carcinoma. You mentioned about prostate carcinoma and flexible cystoscopy. What you mean by?
No, bladder carcinoma. If the patient had a history of earlier history of bladder carcinoma, I'll consider not prostate.
Yeah, mainly the recurrent urinary tract infections and complicated and persistent pain with LUTS symptoms. So you are thinking other than the LUTS, there are associated things where you have to evaluate, then you will consider the flexible cystoscopy. Am I right, sir?
Yeah, that's right. I think it has to be some specific indications, not for everyone.
Not
for everybody, the flexible, yeah. And especially if there is sort of history of urethral injuries and urethral discharge in the past. So you're suspecting urethral and young patients, say less than 40, they don't fall into this real BPH category. Then it's worth excluding outlet obstruction due to other causes like urethral strictures. So, because otherwise, if you start medical management without it, you might be managing, it's not in the most correct way.
Yes, that's good. Other things after that you said about the starting alpha blockers. So do you what you will advise before giving alpha blockers, and how are you going to take this patient? The alpha blocker is going to be taken by the patient.
Yes. So as it is first line treatment, I'll counsel the patient regarding the drug, the dose, and the way he need to take the drug, and I'll educate him about the side effects of the drug and the duration of the drug, which he might experience the reduction of the symptoms. Alpha blockers will act about within days, but sometimes it will take about weeks to give symptom reduction. And about side effects, educate the patient about first dose hypertension, although it is less because it's a selective alpha-1 blockage, but still patient might feel hypertension if he's having concurrent any other drugs as well. So nighttime drug usage would be the ideal time, and as well as if like patients who is like sexually active, I'll educate them about the retrograde ejaculation he might experience, and because they might worry about this symptom. And other specific side effects like there's a risk of this if the patient is waiting for eye surgery, they might feel this during cataract surgery, the eye surgeon might feel that fluffy iris syndrome. It's a rare side effect that also should be addressed. And so those are, the drug is like not that side effects profile not there, but there are certain things I need to educate to the patient. And same time, I'll educate about the compliance. He need to take the drug regularly, otherwise he won't feel the proper reduction of the symptoms.
How long it will take to improve the symptoms in a time solution?
They say the drug is quite like it acts within days. So 3 to 5 days time, the drug action will be there. But if the patient's having like prolonged symptoms, it will take. And same time, if the patient's having like both avoiding as well as storage symptoms, the time would extend for like weeks. But the drug action is quite early when compared to the 5-alpha reductase.
You think is it causing any sexual dysfunction with the LUTs? Is there or not?
The association of erectile dysfunction and reduced libido is very minimal with the alpha blockage, but it can be seen with the 5-alpha reductase.
Yes, that's true. What is the rationale in starting tamsulosin only monotherapy, or this patient you are going to start the combination therapy? What is your rationale?
As the patient is having moderate LUTs and post-oil residual is 100, and patient's prostate size is you mentioned about 40, as I remember. And here, as a first line therapy, I'll start with tamsulosin. But if symptoms reduction is not satisfactory, I'll consider adding 5-alpha reductase as a combination therapy. So as a trial,
as an initial point, is there a benefit to start the combination therapy, or you will try it for some time with the tamsulosin and starting the 5-alpha reductase? So what do you...
According to evidence in this patient, the both arms can be attempted, the monotherapy as well as the combination therapy, because prostate size is 40 and he's having moderate symptoms. So combination of monotherapy could be attempted, but if he's well responding with the monotherapy, then I need to get some time to see the response. So if he's well controlled with tamsulosin only, then I can go ahead with tamsulosin. But if patients doesn't have a significant reduction of the symptoms, then I will convert into combination.
Expert panel advisor.
Yeah. What does the MTOP study says about combination treatment and monotherapy? I've heard about the well-known MTOP study, which has been done some time back. So can you tell me about the outcome of it regarding this particular question?
Yeah, according to this MTOP study, sir, that compared to monotherapy, in the combination monotherapy, there will be reduction of this IPS score about 40%, and increase Qmax about 20%. And if we combine with 5-alpha reductase, this increase of IPSS is more, like if 50 to 60% will be there, and reduction of Qmax is also would be much more than the monotherapy cell. So according to the study, it is superior to go for combination rather than monotherapy.
Okay, so this effect is seen after what period of time, according to MTOPS? Because there is another previous study called PLES study, you have heard. PLES was continued up to 1 year, and MTOPS went on up to 5 years and more. So what's the difference between these two very famous studies? What did the PLES say? What did the MTOPS say? Because the difference is the time period.
Yes, sir. In short-term duration, there's no significant reduction of symptoms in the both arms. But if it goes on more than 4 or 5 years, the combination therapy will have more effects because the action of this 5-alpha reductase, it will cause this size shrinkage and more improvement of Qmax.
Yes. So what is the effect of 5-alpha reductase on the prostate in the time scales? How does it act?
Yeah, 5-alpha reductase will reduce, it blocks the 5-alpha reductase enzyme, which will reduce the testosterone conversion into dihydrotestosterone DHT. Thereby, it will lead into the apoptosis of the prostatic epithelial cells, and the prostate size would be shrinkage with the times. And same time, PSA level also will be reduced. So,
what type of time scale are you looking for?
It will, for the action, it will take about more than the action of 5-alpha reductase, it will take about more than 6 months to 12 months, not a short term. And this overall effect can be seen after about 2 to 5 years times.
So is there any indication to give a short-term course of 5-alpha reductase inhibitors? Any indication? What will happen after 6 weeks of 5-alpha reductase inhibitors? Is there any change in the prostate?
The prostate size will be lesser.
Size will start, you just mentioned that size will start getting reduced after 6 months.
After 6 months.
In 6 weeks, the prostate will become evascularized.
Yes.
So vasculature of the prostate will go down. So how can you use this particular effect of the 5-alpha reductase in treating with 5-alpha reductase inhibitors? Devascularization.
Yes. So this additional effect of devascularization can be used if we are planning for surgical treatment specifically, like TURP. So the intraoperative bleeding, the complications can be minimized if we use short-term 5-alpha reductase because of less bleeding.
Also, if he's experiencing prostatic bleeds, frequent prostatic bleeds, 5-alpha reductase. So again, the final question, coming back to PLES and MTOP study, the difference is time scale. So what did the PLES study show?
PLES study shows that by using 5-alpha reductase, the need of surgery will cut down to 50%, nearly 50%. And the chance of having acute retention also will reduce about 50 to 55% in 2 years' time.
Yeah, the study finished around 1 year, and then the final conclusion was finasteride is as good as sugar candy. That was the final comment. It's as good as a placebo. So they nearly gave up. And then when you went on doing the MTOPS for 5 years, what they found was that all the complications got reduced by 70%. But if you go monotherapy, the monotherapy graph and the combination graph, so was there any difference? Towards the end of 5th year, what they found was that the monotherapy cohort developed more higher chance of getting into retention and the complications. The graph flattened off at the far end. So that's why the combination therapy is better than monotherapy. So the monotherapy alone is not going to work. But then later on, how does the prostate size affects this treatment?
In the patients, that prostate size, like it will vary between 50 to 70 years. Like after 70 to 80 years
Sure,
time,
but prostate size and the decision of giving monotherapy or combination, does the prostate weight plays a role according to the guidelines? EAU and
they say around.
do you give everybody? Do you start dual therapy or?
If the prostate size is like less than 40, it is more likely to respond to monotherapy, sir. If the prostate size is more, like more than 40 or more than 30, then there's a place for combination therapy because the size shrinkage will affect his future outcomes.
Yeah, good. So Nabil, you continue with any more questions? So few things I had.
Probably, that's why I just given to the sir there, because asking this trials as well as the explanation will be better regarding the combination therapy rather than the
fine, I think.
That's
it will come from you, it is so.
Yes, sir.
Right.
Yes, sir. So the really, what you know about this, while you're doing a dual therapy, are you considering the 5-alpha reductase, where the finasteride, and regarding the dutasteride? What do you know about that?
In the
Any efficacy outcomes? Yeah.
The outcome wise, the both drugs are having the over the finasteride, dutasteride having the symptom control wise, the outcome is similar, but dutasteride has more inhibitory effect. It will affect both. There are alpha 1 and 2 type receptors. Dutasteride act on both receptors, but finasteride is act on only one receptors only. So it is selectively act on prostate mainly, but dutasteride it will act about. Apart from prostate, there are other extra effects as well, like skin, liver effects also there. So prostate symptom wise, the efficacy is like similar according to the EUA, I remember, but the side effect profiles and other effects are more on dutasteride.
May I stop you for a minute, Shankar? Now you made an error there. So can you correct it? The mode of action? The mode of action. You said something about alpha-1A, that is for alpha blockers. So what is the difference between finasteride and dutasteride? What does it really block, the two drugs?
The 5-alpha reductase.
So there are 2 isoenzymes. There are actually 4 isoenzymes. Out of them, only 2 are actually concentrated in the prostate. So mention it's the isoenzymes, not the alpha-1 synthesizer, right? That is for the alpha blockers. Yeah, so these are fundamental things. Be very careful about, making it, right?
Mainly the type 2 isoenzyme will be in the intraprostatic tissues, as well as type 1 in the liver and the skin will be there. So that the action will be on both enzymes. So that is the thing I expected. So, right, okay. Then you know about the dutasteride combination, because they have added some studies regarding the dutasteride, including rather than the finasteride, like MTOPS in the finasteride, where are there studies with the dutasteride? Do you know any studies?
There's I can't remember the exact names.
Yeah, combat trial. Yes, they have combat trial. Yes, that's where they have their combination therapy have effective, including the dutasteride. They have shown, right? So, anything, sir, want to tell in that combat trial, sir?
Combined trial, I think basically what it has shown is that, best of my knowledge, more or less it's same effect when it comes to the final complications and the outcome. And then only thing is that the sexual side effects were a little more in due to strike group. So and you must be knowing better than me about it. So does it give any details about this combination, this comparison of these two? What was the real outcome? I'm asking you.
For me.
Yeah.
So the real outcome was the equal effective. That's when compared to the finasteride and the dutasteride, both are same effective.
Yes.
Wise. That's mainly the outcomes, and the sexual dysfunction vice versa. That's what they have called. Yes, sir.
That's right. That's fine.
And, other things, Madhushanka, mainly is there if a patient who is with a LUTS, with a sexual dysfunction, with or without sexual dysfunction, is there any role play in other drugs rather than this regarding sexual dysfunction, like mainly the erectile dysfunction?
Yes, if apart from LUTS, if the patient is having concurrent sexual dysfunction, I'll assess it by using a questionnaire like IIEF. Then if he's having combined symptoms with tamsulosin, I can combine it with like sildenafil or tadalafil, where that drug also will cause a reduction of LUTS, as well as it will improve his sexual symptoms as well. So
is there a possibility? Sorry, Varshanka. Is there a possibility of taking as a monotherapy, like antiphosphodiesterase inhibitors? What you also told.
They are not recommending monotherapy of like sildenafil or tadalafil monotherapy, but combination with alpha blockers, it has proven efficacy.
Sir, what about that statement?
Yeah, I think that they need to be little corrected, because now instead of alpha blockers, you can replace the alpha blocker with tadalafil low dose. I think tadalafil generally 10 milligrams of 20 milligrams are needed for erectile dysfunction. While if you give a continuous dose of 5 milligrams daily, that will relax the bladder neck and the prostatic musculature equal to the alpha blockers. So I think if somebody is having ED and BPH, you can definitely give this tadalafil. The trials are only there for tadalafil, not for sildenafil, which is a short-acting thing. Tadalafil goes on for 18 hours. So if you are giving it for prostate, your low dose and daily dose. Only risk is that while you are on that, you can't take nitrates. So because nitrates are contraindicated, so if you get a chest pain or something like that, so people with IHD, ischemic heart disease, we have to be little careful about putting them on long-term daily dose of tadalafil. So that is it. But it has come as a replacement of alpha blockers. Though I have come across people who take both alpha blocker and tadalafil, I think I can't think of a rationale for that, because both are muscle relaxants, smooth muscle relaxants, and act on the bladder neck and the prostatic sphincter. That is the prostatic smooth muscles.
Yes, sir. That's what I also got to know and gone through there, because the only cost is the problem, because alone if you are taking the phosphodiesterase inhibitor, tadalafil will be more costly rather than the tamsulosin, but the same effect you will get in the of the bladder neck relaxation. So if you have the sexual dysfunction, it will be better like that. That's how they are taking, sir. Yes. And that's other things. Is there any role play in the LUTS evaluation is the anticholinergics? When you will consider, are you consider alone or combination?
In the LUTS evaluation, if the patient is having, apart from LUTS, the features of storage symptoms or the features of overactive bladder, or if we happen to do urodynamics, if it shows like a concurrent overactive or bladder hyperactivity, to reduce storage symptoms, I can combine with the alpha blockers as well as the anticholinergics. where I can use the M3 receptor blockers. There are various drugs, sulfanesine, tolterodine. So I can combine with them.
Right. I'm asking that are you going to urodynamics and assess and give, or otherwise you will just give it, because the patient who is having a lot symptoms while you are evaluating, sometimes this patient having some increased frequency and nocturia might have coexisting, because you know the pathophysiology. Can you explain the pathophysiology? If a patient who having a nocturia, those who having a bladder outflow obstruction.
So initially, patient will have this storage symptoms of blood outflow obstruction. So with the time, due to this persistent outflow obstruction, the detrusor get hyperactive. So some group of patients will have this detrusor muscle irritative symptoms like this frequency, urgency, and nocturia. And so pathophysiology wise, it's basically because of the long-term obstruction of the bladder, the detrusor muscle get overactive or this hyperactive.
Yeah, in that other things, in the night time, the patient having nocturia, other possibilities?
Then I have to think about other polyuric conditions as well, apart from the blood outflow obstruction, whether the patient's producing a lot of producing a lot of urine due to any diuretics or any other medical conditions. So that part also I need to exclude.
Okay. Sir, any comments, sir?
Yes, nocturnal polyuria is something you have to exclude very clearly in these patients. So, Shanta, do you know how to do that? How will you do that? How will you exclude the nocturnal polyuria, differentiate it from the nocturia or nocturnal frequency?
So I can use a frequency volume chart for that, sir. Ask the patient to measure the volume as well as the frequency of urine. I can use a like 24-hour for consecutive for 3 days, and there I can assess separately the daytime as well as the nocturnal time, the urine volume. And specifically here, I'll concern about the nocturnal urine output, the frequency as well as the volume, the out of total 24-hour volume, whether how fraction of the volume is passing like nocturnal basis.
What fraction?
Yeah.
What fraction you will consider as a nocturnal polyuria? If a volume is normal, total volume is normal, then what is the fraction you will consider according to the age group or whatever, roughly what you will consider nocturnal polyuria?
Exact number I can't remember, but like if it is like more than 50%, if he's passing like nocturnal time.
If it is in the elderly, some of the studies they saw, but at least 1/3, because they said averagely more than 33% of the volume in the night time. According to sleep, you have to take the sleep time and the duration and everything, because sometimes some people they sleep 4 hours, 5 hours, because according to the time it will be vary. But more than 1/3 of the volume is considered is a nocturnal polyuria if volume is normal. As I am correct, sir?
Yes. The thing is that the night 8 hours, the night nocturnal production of urine also goes down due to secretion of various hypothalamic enzymes like natriuretic factor and things like that, and atrial natriuretic factor. So the nighttime urine production should not be exactly 1/3 of the daytime production. So if you divide the whole day into 8-hour quotas, nighttime production should be less than 2/3 of the daytime 8-hour quota, because that's a natural way of keeping the bladder, prevent the bladder overfilling. So the bladder volume, you have to calculate it in such a way that bladder volume is about 350 cc. So if you produce like daytime rate, 360 milliliters will get filled up in 6 hours time. So everybody will get up in the night. So because if you are going to have an 8-hour sleep, so that's the basis of cutting down the fluid in the evening also. So natural antidiuresis, which occurs in the night time, will be disturbed in some of these diseases. So they like diabetes and all the other things leading to nocturnal polyuria. So the nocturnal urine output should be measured separately and see whether it is more than the 2/3 of the 8-hour urine production of the normal person. So that's how you calculate the nocturnal polyuria. So, and then you look for another cause. And you have to look for the other cause of nocturnal enuresis also, that is nocturia, because a person who is having a low capacity bladder, that there will be a nocturia because the bladder cannot. So always better to check the ultrasound scan to get some idea about his functional bladder capacity. Suppose daytime functional bladder capacity is 150 cc, that is the reason for his nocturia as well. So these little factors you have to consider. So separating nocturnal polyuria and nocturia is important when it comes to treatment. Otherwise, what will happen is we will put all of them on anticholinergics, and which will not work. Because the nocturnal polyuria, the treatment is different. Because you have to cut down the nocturnal urine production. So, so that is those are my comments about the nocturia. But better to be thorough with the exact figures and things like that.
Yes.
Okay. Thank you, sir. I conclude the medical management as well as your parts. I think that
one more thing, Nabil. One more thing, Nabil.
Okay.
Is Madhushanta, you should mention about so when you are adding an anticoagulant, what is the most important thing you must look for? Will you add now, somebody is LUTs, and then you are given dual therapy already, what will keep you away from adding an anticholinergic? When you do not add, the guideline says that very clearly here.
If the patient is having a risk of getting urine retention, sir, the high IPSS, the intraprostatic perfusion is more.
No, it is non-specific. More than 150 cc of phosphoid residual, you are not supposed to start the anticholinergic. Then there is a high chance of going into retention. That is given, the figures are given in the guidelines.
Thank you, sir. That's I forgot to ask that question. I kept in mind. I forgot.
No problem.
Okay, I think that Madhushankar has given a good elaboration. I think that I conclude with the Madhushankar's discussion. Is it okay, Dr. Munupriya, sir?
Yes, Nabil. Shall we move into the next one?
Yeah, I think almost 1 hour has gone.
Yes.
Because the first session, I think we will have to, we'll get to know the problems, practical problems. So next time we can use them.
Right.
Thank you.
Dunita?
Yes, sir.
Right. So now you have to think about this is the exit exam Viva. And so I will give the questions. You have to answer as a exam without looking at the computer papers or like that. So try to do the as exam wise. So shall we start now?
Okay.
Right. Okay. So there is a 75-year-old gentleman present with history of nocturnal enuresis for the last 3 months. He never had these symptoms in the past. He has been seen by SHO who insert the catheter as patient had palpable bladder but not discomfort. Post-catheterization volume is recorded as 1.5 liters. When you see him on the ward, he is stable, producing around 100 milliliters to a urine per hour, and the BP also stable. How would you decide if this patient has acute or chronic retention?
First of all, sir, I will go through the patient's history again, sir, and reevaluate the patient's storage and voiding symptoms which had been there for last 3 months, other than this nocturnal enuresis. So as the patient is having a palpable bladder, which was on admission, patient was not in pain, with a palpable bladder with retention. So it is more likely to be chronic retention rather than acute on chronic retention, sir. But
what is acute retention?
yeah, it's a painful condition where the patient is unable to pass urine, and it's acute condition with a palpable bladder, sir.
No, it is a sudden cessation of the micturition with the suprapubic pain and palpable or percussible bladder.
Yes.
Right? Okay. Right. Then patient serum creatinine is within the normal range. Now he has sent for ultrasound scan. It shows no evidence of hydronephrosis as well. And clinically prostate field 50 cc, and even ultrasonically it is around 45, like that. So assuming he is in chronic retention, what are the type of chronic urinary retention and what is the clinical significance of those types?
Yeah. Patient might be on simple chronic retention, and patient may be on high pressure chronic retention, sir, where the upper tracts will be dilated and associated renal impairment as well as newly diagnosed hypertension, and with the history of nocturnal enuresis. So if the patient is on high pressure chronic retention, patient should not be offered trial without catheter, and patient should be offered TURP, surgical management. But in patient with chronic retention, we can start medical management and offer trial without catheter.
Right. So if the patient is having high pressure chronic retention, ultrasonically, what are the features you can see in high pressure chronic retention? Now patient is with the catheter, radiology team asks you to send the patient with full bladder. So ward people has clamped the catheter and send the patient for ultrasound scan. What are the important things you request from the ultrasound scan, and what are the things you want to look in ultrasound scan?
I want to see whether there is any upper tract dilatation. It is hydronephrosis and hydroureter.
In which phase? The full bladder or empty bladder or both?
Sorry, sir, I didn't get that.
So in ultrasound scan, you want to see the upper tract.
Yes, sir.
Right. So in upper tract dilatation in full bladder, empty bladder, or both?
Yeah, in high pressure chronic retention, there will be upper tract dilatation, so initially, but even after decompression also, there might be upper tract dilatation. It won't resolve even just after catheterization, sir. So there will be, even with the catheter, sir, there will be upper tract dilatation, sir.
So what it shows, when we do the catheter and in empty bladder also same type of upper tract dilatation is there, that means what will be the results? Where the problem is?
Sorry, sir, I'm not sure that.
So when the patient is catheterized, if due to the reflux, high pressure chronic retention, high pressure in the bladder, with that reflux only causing this upper tract dilatation in empty bladder, it will resolve, or at least moderate hydronephrosis come to mild. Yes, right. If the symptoms, the upper tract dilatation is persist, where the problem is?
But just after releasing the pressure, even if it is persisting, we can't.
No, even after.
Say that.
Even few hours after, the dilatation is persist. Have you heard the UV nipping?
UV nipping is proximal to the bladder, so it has to be some
bladder wall thickening and causing the obstruction in the uretero-vesicoureteric junction level. So in that patient,
Yes.
management will be different. Okay.
Yeah.
Right. Based on clinical and biochemical and ultrasonical assessment, this patient most likely have the low pressure chronic retention. Why has he developed nocturnal enuresis? How would you investigate for him his features? Nocturnal. What is the reason for nocturnal enuresis? Patient is having low pressure chronic retention.
Because of the bladder. Yeah. With the blood outflow obstruction, because of prostate enlargement, concomitantly patient may be having detrusophalia as well, sir. So there will be blood outflow obstruction as well as the reduced contractility of the bladder, and over distension of the bladder will be there because of the outflow obstruction, sir. So in that case, large amount of residual volume will give rise to the nocturnal enuresis, sir.
Usually nocturnal enuresis in low pressure system develop because of the during the sleep, the urethral resistance is reduced. Because of that, drop of urine is coming out, not because of the detrusor muscle. Okay. Anyway, what is the investigation you want to do? Further evaluate whether it is a low pressure chronic retention or high pressure chronic retention in objective ways. How you assist?
So patient has to do the invasive urodynamics to confirm the diagnosis, sir.
So in invasive urodynamics, you have to do right. You have to do the assess the detrusor muscle pressure. Detrusor pressure. Okay. Patient undergoes urodynamic study, demonstrate large capacity in bladder, nearly 1,200 ml urine, and his maximum detrusor pressure is 35 water centimeter. And the trust confirmed the prostate is 50. You discuss urodynamic findings with the patient and various management options. What are the management options you can offer?
Either we can go for medical management as well as surgical management, sir. Surgical management would be offering the patient TURP, sir.
So now patient is having chronic retention, more than 2,000 urine. So do you think medical management is enough for this patient or anything else you have to suggest?
Patient would be benefited with the surgical management, sir.
Or otherwise, you have to introduce the medical management plus self-intermittent catheterization, clean self-intermittent catheterization. Okay, right. Patient is not willing for self-intermittent catheterization, but patient happy to do the trial of surgery. What additional procedure you would consider during the TURP and why? Now, patient is not willing to do the self-intermittent catheterization. That is a clue.
Sorry, sir, I'm not sure.
So if the patient undergoes a trial of surgery, that means TURP.
Yes, sir.
Even after patient can fail the passing urine because detrusor may be inadequate to pass the urine. So in that case, patient should go for a self-intermittent catheterization in this type of patient or in-welling catheter. So patient is not willing. So what are the options for that patient? Now you have done the TURP. Again, patient's bladder is palpable, not passing urine properly. Patient refused indwelling catheter and the CIC.
So in that case, patient should be offered suprapubic catheter.
Right.
Patient is not willing for.
Yeah. So because of that, you can discuss with the patient before the surgery. If you don't willing for after the surgical trial, if failing that, we have to go for a self-intermittent catheterization. If you refuse persistently during surgery, we can put the suprapubic catheter. If you can pass the urine, we will remove that.
Yeah.
So that is the one option. Okay, right.
Yes, sir.
What findings on urodynamic assessment would give you some confidence that TURP might work?
I'm not sure, sir.
So now patient is on chronic retention, low
Yeah.
pressure chronic retention. You have done the advanced urodynamics. In advanced urodynamics, what findings is help you to say the TURP might work? What
The
pressure?
detrusor pressure is
Yes.
detrusor pressure.
What is the target pressure you want to?
I'm not sure the values, sir, but the
About
patient is having
35
good
watt
35.
centimeter. Right. So, what is your standard approach in managing patient with low pressure chronic retention?
So, if the patient is having a very high residual value, residual volumes, so even with a high residual volume, we can trial without catheter, but there's a high chance of failing of trial without catheter. So in that case, we have discussed the available options like the TURP or attempt trial without catheter, managing the medical management, continuing medical management with the patients. So
my question is your standard approach for the low pressure chronic retention.
I will start with medical management, sir. Initially, alpha blockers combined with alpha reductase inhibitors because prostate size is more than 40 grams for this patient.
Do you want to catheterize?
So, as the patient is already catheterized, I will offer him trial without catheter.
Not in this patient. In low pressure chronic retention, you are seeing the first.
Yeah, no need to catheterize, sir. I will.
So, how you manage? What are the important instructions you want to give to the patient?
So, first of all, I will assess the patients with ultrasound scan residual volumes and have an idea of the residual volume of the patients, as well as the I will do the as a baseline measure. I will do the uroflowmetry and have an idea about the Qmax.
So in ultrasound scan, more than 1000 prevoidal and the postvoidal around 600 ml or 500 ml, right? And flow is poor flow. Qmax is around 12, but average is 6, 7, like that. Void in time is 90 seconds.
Yeah. So I will start medical management with alpha blockers as well as 5-alpha reductase inhibitors. Meanwhile, I will adjust patients' lifestyle modification as well, sir, because we have to make sure that the patient is. I will go through the frequency volume chart and patient's fluid intake. I will cut down the fluid intake at night as well as the whether the patient is on medications which might precipitate the his symptoms. So with all this, I will try with the medical management initially, sir.
What is bladder retraining? What is bladder retraining? Have you ever heard?
Yes, sir.
What is?
Sorry, sir, I'm not sure that to explain.
So in chronic retention patient, the problem is the prevoidal volume is large. To prevent that, what should you do? What you ask patient to do? Time voiding.
Time voiding.
3 to 4 hours time patient should pass the urine. Prevent the over distension of the bladder. Second one is residual volume. How to reduce the residual volume?
Double voiding.
Double voiding.
Frequent.
Yes. So those are the bladder retraining. With the medical management, you can do the bladder retraining. And Afterwards, as you mentioned, TURP. So if the TURP is poor outcome, you can ask patient to CIC. Up to that level, avoid the indwelling catheterization for the low pressure chronic retention patient. That is the standard management. Right. Now, what if the patient is the previous patient refused the CIC? We gave the trial of surgery. At the same time, we put the suprapubic catheter. What risk you would explain to the patient in long-term suprapubic catheter?
So I will tell the patient that the patient has to be on suprapubic catheter and it has to be changed. And
what are the risks of having suprapubic catheter?
And persistent suprapubic catheters cause bladder irritation, persistent irritation, and metaplasia. It might cause metaplasia as well, so in long term, as a long term risk. And
so metaplasia and bladder cancer in suprapubic catheter, at least how many years you have to be with the suprapubic catheter?
It has to be at least more than 10 years. So it's very long.
More than 10 years,
10
right?
Years.
So other problems with the suprapubic catheter? Recurrent infection, stone formation, suprapubic catheter blockage.
Yes, sir.
And the bladder shrinkage, those are the things, right? How does the management of high pressure chronic retention differ from the low pressure chronic retention?
Yeah, high pressure chronic retention patients, we can't offer medical management. So those patients has to be offered TURP, but until the patient is given TURP, we have to keep the patient on catheters.
Right. So once the patient catheterized, any special things you want to see?
Yeah, these patients soon after catheterization, patient might go into decompression hematuria and decompression polyuria. So I will admit the patient and catheterize, and I will measure the hourly urine output, sir. And if it is more than 200 for 2 consecutive hours, I would replace the patient's previous hour urine output. There are various regimes what we are practicing. I will replace the 50% of the previous hour urine output, and will monitor the patient's electrolyte levels, mainly sodium levels, and I will measure the patient's daily weight and admission weight as well as daily weights, and I will observe for the polyuria, and decompression hematuria will settle its own.
So what are the instruction you want to give to your house officer and the nursing staff after catheterization? One thing is you want to monitor the urine output. Anything else?
Monitor the hourly urine output as well as patient's blood pressure and electrolytes mainly, sir.
How frequently you want to do the electrolytes?
Daily electrolyte will be adequate, sir.
That is depend on the urine out with the urine out.
Yeah. Yes.
If the patient is producing more urine output, you might need a 4-hourly electrolyte assessment. And the patient's conscious level you should observe.
Yes.
Why?
Decompression polyuria, and the patient might go into hyponatremia. So hyponatremia will cause confusion, neurological symptoms.
Because of the brain swelling and those things. But elderly patients, less, because of the space is there. Okay,
yes.
Right. Before moving into further, still we don't complete the 20 minutes, right? Okay. You are now, we will move to next part of the complication of the BPH and those things, right? And now you are doing theater list and are just about to send the next your case. That is a hydrocele repair. Okay. When the nurse from the recovery rush to you and tell patient, you have done the TURP and send the patient to recovery, Now patient is not doing well. What will you do?
So as the patient is in the recovery, sir, I will assess the patient again, sir, and check the vitals, blood pressure, pulse rate, as well as the patient's conscious level, sir, and see whether the patient is. I will examine the patient's abdomen with the signs of extravasation of urine, and if there's tenderness in the suprapubic region, and then I will check the catheter whether the patient is having hematuria, which is not there at the end of the surgery, sir. So with that, I will. My main concern is whether the patient is in TUR syndrome, even though it's rare, but it's a sinister complication. So I will. My main aim is to exclude the TURP syndrome here, sir. So I will urgently send serum electrolyte for the assessments for the serum electrolytes, and I will inform my anesthetist, and I will keep continuing monitoring the patient, sir.
Right. On examination, you found your findings. You found that catheter is blocked and bright hematuria in the back. How will you manage this problem?
So first of all, as the catheter is blocked with the catheter, so I will flush the catheter with the 20 cc syringe with the normal saline and see whether the obstruction is relieved, sir. So if I'm able to relieve the obstruction, I will flush it, and then I will see whether the ongoing hematuria is there or not. If there's ongoing hematuria, sir, first of all, I will apply traction and see whether the what will happen to the hematuria, sir. So if it is not responding with that, sir, I will increase the amount of distal water in the balloon, 30 cc, and then with the traction, I will reassess the hematuria again, sir.
It's still not settled.
Yeah, in that case, I must discuss with my anesthetist, and I will take back the patient into the theater, and I will again insert the receptoscope, initially cystoscope, and evacuate the already formed clots, and then with the rollable diathermy, I will diatomize there's a posterior bleeder, especially at the bladder neck here, sir.
There is a large bleeding from the lateral wall. You can see the capsular breaching as well.
Yeah, in that case, I will insert a size 20 to gauge 3-way catheter and increase the size of the balloon to 30 cc, and I will apply traction and see whether it might settle or not, sir.
If not settle, what are the options, sir?
Yeah, in that case, we have to go for invasive procedures. We have to open up and pack the prosthetic cavity. If there's a bleeder, we have to assist, and if it's not settling, sir, we have to pack and see.
So if you have an interventional radiologist, first you can ask with the interventional radiologist to embolize.
Embolization.
Then, yes. Then if there is no interventional radiology facilities, you can go for a open procedure and the pack and control the bleeding and conservative subsequent management. Right. After unblocking the catheter, you recommend irrigation, urine clear, and you restart your list. However, after the list finishes, you are called to see the gentleman again on the ward, becoming confused. What are you going to do? And what are you what are your concern?
So even this few hours after the surgery, again, my concern is whether the patient is having hyponatremia and cerebral edema causing confusion status. And I will see whether the patient is ongoing hematuria is there or not, sir. If the ongoing hematuria is not there, I will minimize the irrigation, sir. Volume of irrigation, sir. And meanwhile, I will check urgent electrolyte levels and reassess again, sir.
Right. Other than the TURP, what are the other concerns about this patient?
So immediately following TURP, there will be early complications such as anesthesia-related complications like ischemic events can occur. These are elderly patient with a lot of comorbidities. So ischemic event is a possibility. The anesthesia-related complications, deep vein thrombosis and embolism, they are also a possibility. And sepsis, localized
Yes.
sepsis, as well as systemic sepsis is also a possibility. It's about 3% in systemic sepsis.
Good. Right. On examination, he appears fluid overload and shortness of breath. And you get the blood reports. Sodium 115, potassium 4, creatinine is around 100, blood urea 6, and hemoglobin is 10, pre-op is 12.8. What do you think?
Basically, patient is having hyponatremia. So my probable diagnosis is TURP syndrome. So as the patient's blood pressure is stable, I will initially start with IV furosemide 40 milligram bolus dose. And with that, I will get my endocrinologist or medic for the further management of hyponatremia.
What is TURP syndrome?
It is a rare but significant complication of following TURP due to the causing dilution of hyponatremia and fluid overload following absorption of large amount of irrigation fluid during surgery.
So that means hypervolemic hyponatremia.
Hyponatremia, yes, sir.
Right. What are the classical signs and the symptoms are suggestive of TURP syndrome?
Initially, there will be neurological symptoms and
what are the neurological
mainly
symptoms?
The patient's confusion, altered level of consciousness, and those are the initial main presentations of TURP syndrome. Then later on, patient might go into arrhythmia, cardiac
initiate with the restlessness, confusion,
yes,
dizziness, headache. Those are the neurological signs. Okay. Cardiovascular wise?
Cardiovascular wise, there will be arrhythmias and some might cause bradycardia, but rarely it can cause tachycardia as well, sir. And causing hypotension.
High blood pressure, systolic and diastolic high blood pressure, cyanosis, and the cardiac arrhythmias.
Yes.
Respiratory?
Respiratory wise, patient may be having difficulty in breathing, sir. Tachypnea mainly.
Tight feeling of the chest and the throat. Maybe patient might say difficult to breathe, difficult to talk, like that. What is the GI symptoms?
Patient may be nauseating initially, nausea and vomiting.
Yeah, retching nausea and the abdominal pain, those things. Right. What are the manifestation of different level of hyponatremia?
Initially, we can categorize them mild, moderate, and severe. Sir. So initially, there will be a confusional status, as we mentioned earlier, sir. And with the very low levels of sodium levels, the patient might go into seizures, convulsions also, sir. And
so if the sodium level is less than 120, hypotension, myocardial reduce the myocardial contractibility, those things. Less than 115, bradycardia, QR complex widening, ventricular ectopics, T waves inversions. If below 100, generalized seizure, coma, respiratory arrest, ventricular tachycardia, fibrillation, cardiac arrest. So with the sodium levels, you might know about those things. How will you manage TURP syndrome?
First, once I confirm the TURP syndrome, I will start resuscitating the patients. As soon as confirmed TURP syndrome will start IV.
Suppose you are operating the patient and patient is developing TURP syndrome while on operation.
Right.
What should you do?
In that case, I will quickly finish off the surgery. So I will achieve hemostasis and I will insert a 3-way catheter and finish off the surgery as soon as we confirm whether the patient is in the TURP syndrome, sir. And then I will ask my anesthetist to give a IV furosemide bolus dose and then continue monitoring.
How much?
And
How much
40
of
milligrams,
furosemide?
40 milligrams. So depend on the blood pressure. So it is the patient is after spinal
So,
anesthesia, the patient's
So ideally 1 milligram per kg
yes,
intravenously.
yes.
Okay. And anything else?
Uh, uh,
Anesthesia point of view, they should give the oxygen. For
Oxygen
the
and
pulmonary edema, may need
intubation,
intubation.
sir. Patient.
Okay. Right. Anything else? How you correct the sodium?
So you have to, we should not rapidly correct sodium levels, sir. We have to gradually do it by restricting the fluids and gradually let it come back to normal, sir. So if you are replacing sodium, it has to be done under with the opinion of endocrinologist, sir.
Okay. So usually if you are the replacing sodium, it should not more than the 0.5 milliequal per hour.
Yeah.
Right. Then volume wise, not more than the 100 ml per hour. Right. 2/3 of saline given restore the serum sodium level and the osmolarity. 1/3 distribute the water cell extravasation. Those things will happen. Right. Okay. Then what are the factors you want to correct in the TURP syndrome? So you have to monitor the calcium levels.
Calcium levels.
Anything else?
And
if the patient develops seizures,
yeah, if the patient develops seizures, we have to give sedation, sir, but diazepam or midazolam to control the seizure initially, and then you have to monitor the cardiac arrhythmias, ECG level has to monitor continuously. Patient might go into arrhythmias, and
if DIC,
yeah, coagulation status has to be checked, sir. Rotam has to be done, and patient's coagulation status has to be assessed body.
So if there is a retroperitoneal fluid and maybe some fluid extravasation in the abdomen, in that case?
In that case, patient will be benefited with the retroperitoneal drain, sir.
Right. How will you prevent TUR syndrome?
So there are pre-operative measures, intraoperative measures. So pre-operative measures are we have to optimize the patient's sodium levels before the surgery. That is one thing, and we have to have an idea about the size of the prostate. Sir. If it is a fairly big prostate, we have to get ready with the pre-operative. We have to do the TURIS or open surgery or a less enucleation HOLEP-like procedure rather than going for a conventional TURP. So during intraoperative, sir, again technical stuffs are there, sir, and the technical stuffs are maintain the water column height, sir. It should not be too high to increase the pressure, and during surgery you have to achieve hemostasis then and there.
What is the height you want to keep the water column?
The recommended one is 70 centimeters, but which is adequate enough to maintain a good flow has to be there, sir.
Okay, less than 90 centimeters, no? Right. Okay.
Yeah.
Ideally 60 to 90, between the 60 to 90, you have to keep. Okay. Further?
Do
you want to do the preoperative electrolytes?
Yes, preoperative sodium levels has to be assessed, and sodium levels has to be within normal range, sir.
For all the patient, no, you have to do the selective patients electrolyte assessment.
Not in all the patients, sir. If the patient is, if you are going for a resection of very large prostate, then sodium levels has to be to prevent TURP syndromes.
Why not a small prostate? If you use the water, every patient's electrolytes you should monitor.
Yes.
Okay. So you can't say if the small prostate can go into the TURP syndrome if the sodium level is low. So you have to monitor the electrolyte for if you do the water resection. Okay, you have answered well. We'll ask Neville sir's opinion as well. Neville sir?
Yes. Yeah, it's a kind of a roller coaster session on prostate. So I'm sure Dunita will need a second dinner for this. And it will be a glass of water as well. But the exam, I think, is definitely going to be much easier, and the examiners will be more sympathetic towards you than Munipri. Okay, so wish that he will not come as an examiner. No, I think he's very good. He has got well prepared. So what my observations are that I think we should in future. I think this Dunita's interview went on for about how much? About 45 minutes? No, 40 minutes. So she can't shorter and involve more candidates, and then the questions. I mean, when we are questioning the examiners, we use. I mean, the last time and the other things, we have a marking scheme. So I think these questions very direct, and they have to be very clear and succinct, so that it's a very direct question. The candidate are expecting a very clear answer from the candidate, and then for each point, now we expect 3 to 5 points from each question. So if you can give 1 to 5 marks, and then at the end of the question, now he will answer, he will say something for your question, and then once he said that, okay, I'm done, finished. So if the examiner can say that, well, this is what I expected, 1, 2, 3, 4, 5. Out of that, you have told 3, so you'll get 3 out of 5. So just write it down in a piece of paper. At the end of the 10 questions, or, 15 minutes, you can ask about 10 questions, so maximum 15, 10 questions. You give him a mark. You can send it in private, but then he will know where he stands. And the questions, I think the examiners, and we as examiners, we used to prepare with a marking scheme. It's a must nowadays. So marking scheme, now say if you are asked what are the features of, how do you define chronic hypertension? One question. Okay. So I expect them to say that it is the chronic retention, and then there is upper tract dilatation and signs of renal failure associated with hypertension. Those 4 features have to be mentioned, because this chronic hypertension is a funny concept which is accepted by the British but rejected by the Americans. Americans say this chronic hypertension is part of the process of outlet obstruction, and there is nothing called special chronic hypertension. So British, they defined it as these 4 features. I'm just giving an example. So just if those 4 points are given, so if he has told all 4, you say 4 out of 4. Otherwise, if he says only chronic retention, if you have not mentioned hypertension, if he has not mentioned renal failure, signs of renal impairment, then you get 2 out of 4. And just as an example. So I think the examiners can do that, and then ask very clear questions. How would you prevent? What are the steps you will take to prevent TURP syndrome? So, and you expect him to say 5 points. 5 points, I need not to classify, but 5 points, like say, preoperatively, know the pre-existing hypomonatremias, and then say during surgery, keep the time up to less than 1 hour, okay, and then keep the pressure less than 90 centimeters, the mitigation pressure, and then use non-electrolytes rather than non-electrolytes, and use bipolar diathermy. Like that, whatever the points you expect. So write it down and then give 1 mark for each out of 5. So if you ask 10 questions, 5 points each. So if he has mentioned that, you have to write more points. So out of that, if he gives a reasonable number, more than half of the questions, he will pass. So that way, I think objectively we can assess candidate. And I think we should shrink this time period for each candidate to strictly to about say 15 minutes or so. So they can, so during this period, you can examine more people and maybe more examiners as well. So that is one thing. So that is my observation. So in future, we can use that. I think I think Muni taught a lot, I think, in this session. I think what you have to say is at the end of the answer, you tell what you expect. Very clearly say that this is what I expected, but you told only this much, so you will get half of the mark.
Right.
So I think this type of mock exams and training sessions, that is important. Otherwise, I think it's very good. I must congratulate. So are we going to have any more? Or this is going to be the end? Sunita has to go and have a bath and come back, so change his clothes, give a fresh look. Right. Okay. So I think it went on very well. So are there any other candidates? So it's only these two.
Only today these two.
Yeah. So I think it's a massive subject you covered in one session, this VPH. So maybe if you have more sessions, I think we can divide into these sections. So I think the next time, I think we'll make it questions very clear.
Okay,
so that I could see that Dunita is asking pardon, it's not very clear, I'm not quite sure. So, I mean, that hesitation and the time gap is crucial. Time is running fast. So if the question is not clear, so just always say that, sir, can you, so whatever it is, can you rephrase it? Rephrase means you are not clear. Telling it in a polite way. Okay. So, other thing is that as examiners, I think what you should do is if he's stuck in one thing, you move on to your next question. So if you think that you have asked the question, that person is not coming out, he's sort of hesitating, that means he doesn't know. So I just don't sort of wait or just go to the other question. But you have to sort of give 0, 1 out of 5 for that question. Right. So I think for the next, for the examiners, I'm telling. Yeah. Facts-wise, I think Dunita has to polish his theory knowledge a little bit more because this QRP and BPH are very basic topics. So you have to know the details because these are very commonly done operation. Then that, facts-wise, right. Yeah, I think about other than that, it's fairly good, really.
Yeah. Okay. So I thought that there are other things which was not covered because intraoperative, the surgical techniques and the type of surgeries which have not.
We will do. We will do the separate session for that.
Separate session. Yes. That will be good.
Yeah, I think that URP and the alternatives for that, and then that will be a different question line. So the new technology, that is, I mean, we used to cover in Uromet, the last session, the Eurotechnology part, I think we used to cover that. So you can have it as a Viva. Because Eurotechnology Viva is there, a separate section out of the 6 sections in this. As you know, Eurotechnology is one of the parts in the Vivas. So we can do that. And don't forget about this practical point. Trying the internal iliac arteries. Massive bleeding in after TURP, especially people who have been on anticoagulants. Continuous bleeding. No interventional radiologist. You have opened up, packed intraprostatic, periprostatic packing. Nothing stops. It keep on bleeding. Just don't think twice. Open up. Anyway, it's opened up. Go for the internal iliacs and tie them. It's a very simple job. I think as surgeons, I think you have to be very conversant. Occasionally, you will be called by the VOGs as well when post-hysterectomy bleeding and severe bleeding is there. So be very conversant with that. Don't think twice. Don't wait for the intervention. They used to come next day or later on. Just tie the internal iliac arteries. Okay. And that will stop 70% of bleeding, and miraculously the bleeding will stop. I'm sure Muni would have seen us doing it when you were here. Yeah, it's a life-saving measure. Huh? Yeah. So, and urodynamics, I think Punit was asked about it, isn't it? Urodynamics figures you have to be very thorough with. Okay, the filling pressures less than 10 centimeters of water, and then the sphincter pressure, because we should not forget that there is urethral pressure profilometry, which measures the intraprostatic prostatic sphincter pressure and the external sphincter pressure both, and that is generally over 100 centimeters of water at rest. So when there is voiding phase, micturition, this 100 becomes 40, and the bladder pressure, which has been 10, goes over towards the 100, over 40. That's how you pass urine. The resting sphincter pressure is 100 centimeters of water, and then we are voiding, it comes down to 40, and the
40.
blood to pressure goes up. So those two figures you must try and remember. So because I think when you ask about it, you're a little struggling. And the filling rates, about physiological filling rates, and then non-physiological filling rates, when you are specially diagnosing. I mean, this is not the time to give a lecture on urodynamics, but I think study urodynamics hard because Suddha fellow or the other part of the country, other part of the world, urodynamics is very basic. It's like cardiologists knowing about ECG. So know about the figures. And they should not hesitate interpreting urodynamics. Yeah, I think that is all I have to say about URP syndrome. Yeah. So, and then don't ever forget URP syndrome to add the hemolysis and the renal failure part. Very essential, because you will escape all these other problems like heart failure, pulmonary edema, cerebral edema. But ultimately, you end up, and next day you find that creatinine has gone sky high. That is because of the hemolysis and free hemoglobin clogging the nephrons. So that part should not drop. I didn't hear that being mentioned, but make sure that is a long-term problem in TRP syndrome. And when you are mentioning about water, using water, be very careful. If the Suddha is even observing the examiners, try not to mention that. Say that at least you are using non-hydrochloride solution like glycine, 1.5% glycine, and then glycine toxicity, you have to know about it. Because hardly ever in this world now anybody use. Pakistan, there was one center who was using water like us, but we don't use it anymore. That might give a Suddha, a coronary or something like that. So if you are mentioning about URP syndrome, so it's higher in non-hydrochloride solutions used, that is such as glycine, 1.5% glycine. But then it has its own additional problems like glycine toxicity, which will mimic URP syndrome. Because glycine get converted into ammonia, and then you get encephalopathy. So like that. So so just be a little careful when you are facing international exams. Practically, we do many things, which we should keep it to ourselves. Yeah.
Okay, sir.
Yeah.
We will wind up today's Uromet. Thank you very much, sir. With very short notice, as an expert, you always with us, and thank you very much, sir.
Yeah.
And thank you very much for making this platform for the juniors, Sloughs, and sponsored by the Cipla Pharma. And thank you very much. And all the senior registrars, as a trainees, you join this Uromet because this always we are conducting this for you, because we want to improve our knowledge, our juniors' knowledge, as well as our knowledge, because otherwise we can't go with the globe. So when we go to the foreign conference, we have to fight with them and go with them, how their knowledge is going up, and we have to discuss those matters and that theoretical part with them, then we can get into their platform. And other thing is, I want to say, as a young urological surgeons platform, we are creating the SARC Young Urological Surgeons platform because we want to give more opportunities for our junior consultant as well as trainees. So when we come to the SARC Association of Urological Surgeons, so we always get opportunity to present in the main conference, UAA, SIU, like that. So in that conference, they have separate session for the SARC. So because of that, we can get the opportunity to present those platform. Otherwise, we won't get the opportunity as a Sri Lankan alone. So we have to go with them. So next step is the young urological surgeons. We have to go into that level, and we try to get chance for our residents, that mean the senior registrars, to present in the big fora, and the young consultant as well. So we will try to start from our 25th anniversary. It will be announced by the President Manjula Vijayawardena sir and Dr. Kalana in future, and we are planning for that. So we want to get the separate hall and give opportunity for our trainees as well as the young surgeons. So everything is doing for improve our knowledge, and we want to go with the globe. So please join with this thing.
2 words before I wind up. One thing is that these examiners, potential examiners, I think if they can write down those questionnaires you are going to ask and the answer script keys to those, if you can send it to one of us, I mean, just email it before the session. I can sort of refine it a little bit and then sort of make it more practical. And then number 2 is that second point is that trainees, there are Uromet 1 and 2 videos are all available. So I think before you come for this Viva, you know the section because you're BPH or BPH treatment, whatever it is, just go through it, go through Uromet 1 and 2 videos once more and be prepared with the answers, because those 2 sessions covered a lot of study details and research work and everything, because it was just it was kind of a lecture time. So use that before you come for this practical Viva. So with that, I think I thank both of you and the trainees, and thank you for giving me this opportunity.
Thank you very much, sir.
Good
Thank
night.
you. Okay, good night.
Bye. Good night.